Okay, let's go ahead and get started. A couple of housekeeping items. I wanted to remind everybody that if you are interested in taking my AP2 class in the spring, that it's a hybrid class, and we're trying something very different this next semester. You can register for that class and take it from any campus. You are not, just because I'm in Sevierville, since it's hybrid, you're going to have the option of attending through Zoom or attending in person. If you live in the Sevierville area and it's convenient, you can come to, if you want to, you can come to the on-ground class. Even if you live in the area and don't want to come to class, I won't take it personal, you can still come to class by Zoom. So we're going to give both options here, on ground or Zoom. It'll be the same class. So it doesn't matter where you live, you can attend the class. And we seem to be having some problems at getting that word out to everybody that this is a different approach now. This is what we're trying to do. So just because I'm going to be, because it's listed as hybrid, and doesn't mean that it is a, you can't, it will have a Zoom component. It'd be just like this class, only you have the option of coming to class every day on the ground, or every day we meet on the ground, or coming by Zoom, or any combination that you feel comfortable with. So we're going to make it as convenient as we can for everybody that wants to take it. So anyway, let me finish this. There we go. Okay. And any questions on registration for spring semester, or anything that I can answer? Okay, then one more here. Okay, then I'm going to go ahead and open up the lab, and this comes directly from the 4th unit found in eLearn. So the first part of this, what we're looking at today, is the general senses and reflexes. This is we are literally on the, we're going to wrap up lab, it looks like, before Thanksgiving. We'll see anyway. A sensation. We haven't got to this yet in lecture, but we will shortly. We'll probably be entering sensation and nervous system responses in another week or so. Sensation is the awareness of changes in your environment, either internally or externally. They can be a conscious awareness, like you turn your head when you hear a sound, or your eyes. That's a conscious response. A subconscious change is when your pupils constrict in bright light. So because bright light's too intense, you are aware of external changes. You are aware of internal changes. You are aware of the need to empty your bladder. Your bladder is full, and it wakes you up in the middle of the night, and you got to go pee. And that's a conscious awareness of a change, of an internal change. You have a full bladder. An unconscious change is when you breathe faster after exercise, because your body's pH is dropping because you have too much carbon dioxide. That is a subconscious change. You don't have to be aware of it. You notice you're breathing faster, but your body already was aware of it and decided, hey, you've got too much, your blood pH is too low, you've got too much CO2, better breathe faster to blow off that CO2. That's a subconscious awareness. You didn't have to pay attention to it. It did it automatically. In any sensation, though, you have to have a sensory receptor become stimulated. The sensory receptor has to generate an action potential. We talked about action potentials in lecture today. in both classes today. An action potential, a nerve impulse. The sensory receptor has to be stimulated to generate a nerve impulse. We have to take the stimulus, and the stimulus has to trigger you have to modify, you have to process the stimulus and create a nerve impulse, the action potential. And then you have to process the action potential. Because the sensory receptor, and consider this, what I'm trying to say is the sensory receptor has no idea what it's detecting. It has no idea if it's pain or pressure or temperature or taste or smell or any of this, any of the special senses or any of the general senses. We have no idea what the stimulus is. All our body knows is that a receptor has been stimulated. A pain receptor doesn't tell you it's pain. The only interpretation of that, where we say the integration of the sensory input, takes place in the central nervous system. So the central nervous system detects that it's pain. A receptor that is designed to pick up pain has been stimulated. But all it does is generate an action potential, a nerve impulse that travels to the brain, and there the brain interprets that action potential as, "Ooh, that hurts," or "Ooh, that smells good," or that's a rough surface, or that's a smooth surface, or I'm hot, I'm cold, or that's a bright light, or what's that funny sound, or what's that funny odor. The interpretation, the integration of the sensory input takes place in the central nervous system, but the receptors have no idea what they're actually detecting. All they're doing is responding to a stimulus and generating an action potential. That's all they do. So whether it's a pain receptor or a touch receptor or a pressure receptor or an odor or a taste or a sound receptor, no clue. All they're generating is an action potential that will get interpreted in the central nervous system as what it really is. So, because a pain receptor, I mean, consider when you go to the dentist, consider a pain receptor. If you have dental work done, you usually have some sort of local anesthetic applied to one of the nerves in your mouth. Now, if a pain receptor worked on pain and would tell you that it hurt, if the pain receptor said, "Hey, this really hurts," then a local anesthetic wouldn't work, because a local anesthetic like Novocaine is injected into the nerve that leads to your brain from the pain receptor. And the local anesthetic blocks the pain signal. And the brain actually interprets that signal as pain. If the signal is blocked, the brain doesn't interpret any sensation of pain. Your pain receptors in your mouth, when the dentist is working on your tooth, are still active. They're still generating action potentials, but the action potentials are getting blocked by the anesthetic, so you don't feel it. You don't feel anything. All your touch receptors, your pressure receptors, the whole side of your face is numb. Usually the case, or part of at least the upper half, the side of your face is numb, so you don't feel any sensations, and you're not feeling them because all the Novocaine does is blocks the signals, so they don't get to the brain. The receptors, pressure, touch, pain, are all active. They're still firing away, but they're not being interpreted. So we have the sensation of numbness or no pain or no sensation. So even the absence of a sensation is a sensation. Okay. Before I get too far into that, let me move on. We have sensory receptors that are for the general senses. The general senses are both internal and external, somatic and visceral. Somatic sensations are touch, tactile, thermal, temperature, pain, pain on the surface of your skin, pain within your muscles, and proprioception. Proprioception is position, position of the muscles, position of the bones. Proprioceptors tell us where we are in space. The visceral sensations can still tell us pain, for example, and pressure, but they're internal. If we have a lot of gas in our small intestine, we feel uncomfortable, we feel bloated, as we say. It may even be painful. You may describe it as cramps. It really probably is often just a lot of bloating taking place there, because you've eaten excuse me. Perhaps you had a raisin bran and sauerkraut lunch. Not a good choice if you want to not have a lot of discomfort in the afternoon, because both of them are going to cause bloating and gas formation in the small intestine. That's what they do. You're going to feel pressure, and you may even feel a certain amount of pain here. So visceral sensations and somatic sensations pretty much cover both our body inside and outside. They're keeping us aware of what's going on. We may be aware of temperature changes in our body or not. We may be aware of touch and pressure on the outside. We may feel pain in the viscera. Our appendix may decide it's upset. Our gallbladder may hurt. These are visceral sensations. All these are general senses. They can occur throughout our body. General sensations can occur anywhere. The special senses are different. The special senses are smell and taste, vision, hearing, and equilibrium. And they all take place in our head. They are all very specialized, have very specialized receptors. Smell has the olfactory receptors in our nose. Taste has the taste buds in our mouth. Vision occurs in our eyeballs, or rather just the stimulation of the photoreceptors in our eyeballs. Again, the eye doesn't have any idea what we're seeing. Just like any of the just like any sensory receptor, none of these know what they're responding to. They just respond. When a photoreceptor in your eyeball is stimulated, it generates an action potential that your brain has to interpret. The same with the olfactory receptors in your nose. Your brain has to interpret the odor, taste, and hearing, and balance. We have to be able to adjust our position in space all the time. The receptors that monitor our balance in our inner ear have no idea what it means. They're just stimulated. Okay. So here we see a nerve cell. You've seen this one before back at the beginning of lab. This is a neuron right here. There's the axon. The axon is the long extension of the cytoplasm of the neuron. This is the structure that the neuron, the cell body. This is the cell body up here. The cell body uses the axon to communicate to other neurons, to communicate to muscle cells, to communicate to glands, to tell them all what's going on. Axons are how nerve impulses, action potentials are sent from the cell body down to another neuron or muscle cell or gland. It's the only way that we send signals, the only way we communicate. So that's the axon. The signal starts at the cell body and goes from down the axon. Now, the reception of the stimulus occurs at these structures up here. Okay. There's the nucleus. Yes, okay, thank you. Okay. These fibers here are what we call dendrites. Dendrites are the receiving end, the antenna, if you will, of the neuron. The neuron will receive a sensory input on these dendrites. In fact, I should probably call that a dendrite. I don't think it's a dendrite. Let me go back. I mean, the proper term is a dendrite. Change that real quick. There we go. Oh, I didn't do that. Okay, now let me. There. What happens when you start making changes in the middle of your lecture? Okay. Dendrites. Dendrites are the extensions coming off of the cell body that are designed to receive sensory input. A stimulus is picked up by these dendrites. The dendrites only send signals one way. They send signals to the cell body. The axon sends information away from the cell body. The dendrites are connected to the sensory receptor, or in some places, the dendrite is nothing. The dendrite is the free nerve ending, where the end of the dendrite becomes stimulated. Okay. Now, sensory receptors are designed to respond to changes in their environment. So you have specialized receptors. You have touch receptors, pain receptors, pressure receptors, temperature receptors. You have receptors for everything. And they, and only they, will get stimulated when the appropriate stimulus is applied. A pain receptor will not respond to an odor. A pressure receptor will not respond to a taste. A touch receptor, generally a gentle touch receptor for like discriminating touch, will not detect pain. And pain receptors generally don't pick up temperature. Now they can if the temperature change is severe, but a temperature receptor doesn't usually respond, doesn't trigger pain, and a pain receptor doesn't respond to a temperature change. So these sensory receptors are all going to be specialized, and they're going to create something that we haven't addressed yet. They're going to create what's known as a graded potential. A graded potential. We've just now started talking about action potentials in lecture. We know what an action potential occurs when you depolarize a cell membrane. It depolarizes, it hits threshold, and this action potential runs across the cell membrane and until it stops. It starts and doesn't stop. An action potential is all or nothing. There's no halfway, it's like, well, it's sort of a small action potential, or a very light action potential, or a partial action potential. There's no such thing. Action potentials are all or none. However, we have something in the nervous system called a graded potential. A graded potential is everything that an action potential isn't. A graded potential can be a small stimulus. It can be a partial stimulus. It can be a weak stimulus here. It can be any number of these things here, because a graded potential depends on the strength of the stimulus. And so we generate, it's still a depolarization event. When you put your finger down on something hot and it hurts, you have created to get to that sensation of pain, As you put your finger down on something hot and it hurts. To get to that sensation of pain, the temperature receptors in your finger first had to be stimulated and create a graded potential. The graded potential is a localized, a very localized depolarization event. That depolarization wave may or may not have gotten to the cell body of the neuron. If it didn't get to the cell body, then you didn't sense it. The only way that we actually pick up a stimulus is if a graded potential, a localized depolarization event, is strong enough to reach the cell body. If it doesn't reach the cell body, if it wears out, if it literally runs out, which it will, if it doesn't reach the cell body, if it runs out, then you don't sense it. And there are lots of sensory inputs that we don't detect. You know, there are odors that are below our threshold to pick up. You may smell something that somebody else doesn't. You may hear a sound somebody else doesn't, or somebody may hear something that you can't. Some people have really good vision and some people don't. We're all extremely variable in how we respond to our sensations. And if we can't get it, when a sensory receptor is stimulated, it will depolarize. But will it be strong enough to get to the cell body of the neuron? And if it isn't, then we don't sense it. So while an action potential is often running, when it starts, it runs till it's done. But a graded potential depends very much on the strength of the sensation. How strong is it? You know, action potentials don't care how strong the sensation is. Once the action potential starts, it will run. The only way an action potential determines the strength of a sensation is by stimulating faster and faster. But a graded potential very much is dependent on the strength of the sensation. And if we don't get the sensation to the cell body of the neuron, then we're not going to be aware of it. See, sensation is the awareness of the stimulus. And that leads to perception. It's not enough for the receptor to be stimulated. It has to be stimulated enough to trigger a sensation. And then we have to understand what the sensation is. That's perception. So we have the stimulus, we have sensation, and we have perception. We have to be able to interpret the stimulus. And if any one of those breaks down, then we have nothing. We don't perceive anything. So awareness of the stimulus is sensation. Interpretation of the stimulus is perception. It's the understanding of what the stimulus is. You know, you're aware, you know, when your bladder's full during the night and you have to get up and pee, you're aware of that. You know what that sensation is. It's, I've got to empty my bladder. You know, I shouldn't have had those 3 cups of coffee before I went to bed, or some other favorite beverage. You're aware of that. You know, that sensation penetrates through sleep and wakes you up. You're aware of sounds. You know, you are aware of changes in temperature. You're aware of sounds that stop, like if your air conditioner or your furnace goes out during the night, and the house gets too quiet. That's also tells you something too. Anyway, receptors can be classified. With these sensory receptors we have throughout our body can be classified 3 different ways. By the type of the stimulus, where are they located in the body, and how complex are they? Type of stimulus, we have a variety here. We have what are known as mechanoreceptors. These are mechanical distortions of the receptor. You know, mechanoreceptor vibrates maybe. In our inner ear, we have mechanoreceptors that vibrate when sound waves hit them. That's a mechanoreceptor. When we distort a touch receptor, that's a mechanoreceptor. Thermoreceptors respond to heat and cold. Nociceptors are pain receptors. So we can respond to pain. We respond to internal pain, visceral pain, and we respond to external pain. Photoreceptors, only in our eyeballs, but they respond to vision, light rays hitting the eyeball. Chemical receptors, or what we call chemoreceptors, respond to chemical changes in our body. Like our blood gets too acidic because we're releasing more carbon dioxide. As we oxidize more glucose through cellular respiration, we're generating more CO2, and that's making our blood more acidic because it's forming carbonic acid. And our medulla oblongata in the base of the brainstem says, hey, we're getting too acidic. We better breathe faster and blow off the CO2. That's a chemical change. We got too acidic, or we got too basic, or our blood sugar went up too much and we have to release insulin, or our blood sugar got too low and we had to release glucagon, bring it back up. Those are all chemical changes. And our osmoreceptors monitor our sodium levels in our body. We don't monitor our water level. We don't monitor water level in our bodies, but we monitor salt levels. And by monitoring the salt levels, we can indirectly determine our water levels. Because while we're always losing water, we usually keep the same amount of salt in our bodies. Our water levels can go up or down. And how we know they're going up or down is if our salt levels change. If the salt concentration in our bodies changes, it's because the water level has gone up or gone down. If the salt level in our bodies drops, it's because we've got too much water. If our salt level goes up, it means we have too little water. The actual amount of salt that we have in our body stays about the same, but it gets too dilute or too concentrated. I mean, consider if you have a beaker of salt water sitting on a desk. You put 100 grams of sodium chloride into a liter of water. Okay, so it's a 10% salt solution. If that water evaporates down to 500 milliliters, half a liter, the salt concentration, the amount of salt in the beaker is still 100 grams. But now the concentration in the solution is 20%. The water has doubled its salt percent simply by giving up water. So now we've gone from a 10% salt solution to a 20% salt solution just by losing water. We don't lose salt from evaporation, we only lose water. So, or suppose we take an extra liter of water and dump it into the beaker. It's a big beaker. Now we've taken 100 grams of salt, not in a liter of water, but in 2 liters of water, and now the salt concentration has gone from 10% to 5% because you've doubled the water. We've done nothing to the amount of salt in the water. The amount of salt there is exactly the same. It's still 100 grams, but the water level has doubled from 1 liter to 2 liters. So the percent has been cut in half from 10% to 5%. If we cut the water, take the 1 liter of water and cut it in half to a half a liter, now the salt concentration has doubled. So we don't have to monitor our water levels in our bodies. We just monitor the salt levels. And if our salt concentration goes up, it means that our water is too low. If our salt concentration drops, it means we have too much water. So we pay very close attention to our salt levels. And we respond to very, very small changes in the concentration of the salt. That's what tells us when we get thirsty, for example. So the type of stimulus, let's take a look at tactile stimulus also. These are your touch responses. Touch, pressure, vibration, itch, and tickle These are usually mechanoreceptors. Yeah. There are touch receptors, what we call tactile receptors in the skin. You have what are known as a Meissner corpuscle, a hair root plexus. Now that's a the hair on your skin. When you brush against that hair, you can sense the hair follicles moving. That's the hair root plexus wrapped around the root of the hair that's sticking out of your skin. So we're very sensitive to that. We can detect air moving across our skin when the hair is moving. We have Merkel disc and Ruffini corpuscles. We have Pacinian corpuscles. They're all different types of touch receptors. And we have free nerve endings, which are nothing more than the raw end of the dendrite, just sitting out there waiting to be stimulated. Location-wise, we may be exteroceptors that are on the surface, interoceptors that are internal, internal temperature sensors, internal pressure sensors, temperature sensors. You're aware when you're bloated, you're aware when your bladder is full, you're aware if your gallbladder hurts, you're aware if your appendix hurts, you're aware of any internal pain. So you can have both exteroceptors. We have exteroceptors and interoceptors, external and internal. The proprioceptors are found in our muscles and in our tendons. They detect stretch and contraction. They tell us where our body is at all times. And they work with our equilibrium in the inner ear to tell us these things. They tell us what our arms and legs are doing. You can raise your arm over your head and you don't have to look up at it to see it's there, because you know it's there. The proprioceptors are telling you it's there. So these are the location of our receptors are either outside the body, on the surface of the body, they're internal, or they are embedded in our muscles and tendons. Now the complexity is a little different. Simple receptors. The general senses can be, all the general senses are all touch, pressure, stretch, vibration, temperature, pain, and proprioception. The special senses are, again, hearing, balance, smell, taste, and vision. There are only 5 of them, all located in the head. The general senses are the simple receptors. They're not the specialized receptors. The general senses have very simple receptors. They can, and their endings are either going to be they're going to be encapsulated nerve endings, or they're going to be the free nerve ending. A dendrite, the end of the dendrite is a free nerve ending. If it's covered by layers of connective tissue, it is an encapsulated nerve ending. Now, while we have a certain amount of specialization on our general senses, we say that there is no one receptor, one function relationship, meaning that a touch receptor, there are various types of sensation a touch receptor can pick up. Pain receptors are a little different. Temperature receptors are a little different. They're much more specialized. A receptor that's designed to pick up distortion of the nerve ending is a mechanoreceptor. And so it can have a pretty wide range of activity. There are multiple stimuli that can trigger mechanoreceptors and tactile receptors. But some of these general senses, pain, for example, temperature, for example, are going to be pretty specific. Anyway, the receptors in general senses, all this touch, pressure, pain, stuff like that, are either free nerve endings, the raw end of the dendrite, or the encapsulated nerve ending. They have a layer of connective tissue over them. So the simple receptors, simply the raw nerve ending of the dendrite. Most of our general sensory information is coming in through free nerve endings. Complex receptors are the special senses. We'll talk about them next week. But, again, vision, hearing, balance, smell, and taste. They have very complex sense organs. You can't compare the eyeball to a touch receptor for tactile stimulus. The touch receptor is maybe a free nerve ending, it's just the end of a dendrite. The eyeball is a very sophisticated and complex structure. So the special senses are all located in the head and nowhere else. So the non-encapsulated, the free nerve endings in the skin, in connective tissue, they are simply a little bulb on the end of the dendrite. They respond to temperature, they respond to pain, they respond to light touch. Most of our general senses are going to be free nerve endings. The encapsulated nerve endings are mechanoreceptors. It takes more stimulus to activate them. They're surrounded by a capsule of connective tissue. So even looking at it, it takes a greater stimulus to activate one of these mechanoreceptors. We have Meissner's corpuscles. They are, it is a round receptor located right underneath the surface of the skin. It allows us to have what's known as very discriminating touch. Very sensitive areas, our fingertips, where our fingerprints are located, are covered with Meissner's corpuscles. We can discriminate between soft and softer or smooth. If you work with sandpaper, for example, and you rub your finger across a piece of sandpaper, like if you know what 200 grit is, 200 grit is a very fine surface. It's very smooth. It's designed for finishing up. You start with 200, you finish up with 200 grit. If you want to put a nice smooth surface, actually may it go up to 600 grit. And if you rub your finger across it, it's a very smooth surface. But if you rub your finger across 60 grit, it feels rough and irregular because it's the surface is designed to wear away wood faster. Discriminating touch allows us to tell the difference between fine surfaces. Is this smooth or is this smoother? If you rub your hand across a piece of wood that was sanded with a 60 grit sandpaper, it'll feel smooth until you rub it across something that was sanded with 600 grit. And that feels like glass. What you thought was a nice smooth piece of wood is nothing compared to the final surface, that you've sanded it with 600 grit, because that is like rubbing across glass. Very, very smooth. And the Meissner's corpuscles can discriminate. We can detect these changes in the surface area. Now, underneath the skin, deep in the dermis of the skin, the layer below the epidermis, we have the Pacinian corpuscles. Deep pressure and vibration. A lot of pressure. There's construction going on, and they're blasting, and you get vibration, or a large truck goes by, you're in your car and a very large truck goes by and everything seems to vibrate. Those are the Pacinian corpuscles. They respond to deep pressure and lots of vibration. You've already, you don't stimulate the tactile receptors like the Meissner's. These take a lot of pressure, like a deep tissue massage would stimulate these structures, the Pacinian corpuscles, and they're very deep in the skin. So here's where they're located, for example. Pain receptors near the surface. They are free nerve endings, by the way. There's your Merkel disc right there. It is a very sensitive touch receptor for discriminating touch. Here is a Ruffini corpuscle. It is also a touch receptor. Down here is that Pacinian corpuscle deep in the dermis. This is the one that responds to vibration and pressure. this responds to different types of touch. So we're very, very sensitive to discriminating touch. Lots of these Merkel discs and lots of these Meissner's corpuscles right here. There's the one I was telling you, with sort of like an oval shape, found in our fingertips, underneath our fingerprints. So, yeah. Temperature receptors are all over our body, both internally and externally. They respond to different temperature ranges. They're not all the same structure. Some will respond to changes in heat, and some will respond to changes in cold. We are more sensitive to different parts of our body responding to heat and to cold. Often, extreme temperatures destroy the nerve endings. The temperature receptors, they destroy the nerve endings, and we no longer sense the temperature. And if the temperature receptors are destroyed, usually the next thing that we still pick up is pain. If the pain receptors are destroyed because of extreme temperatures, then we don't sense anything. So temperature receptors work very well, but can't handle the extremes. Once we hit the extremes, then the pain receptors are stimulated. If the sensation increases, it can destroy the pain receptors. Pain receptors are called nociceptors. They are not one of the special senses. Don't get that confused. Lots of people on exams put down pain as one of the special senses, or touch as one of the special senses. They're not. Nociceptors are pain receptors. Pain receptors are our body's way of saying, stop doing that. It tells us that something hurts so we can take action to avoid it. You know, it's what we do so we don't damage ourselves any further. You know, when you put your hand down on something hot, the first thing you do is yank your hand back. Or when you step on something sharp, you yank your foot up. That's your pain receptor, your nociceptor, telling you that hurt, stop doing it. Our nociceptors respond to pressure and temperature, the release of histamine when we are exposed to certain things like pollen, for example. Histamine causes the activation of pain receptors, because what it does, histamine increases blood flow through a region. It causes increased blood flow. It causes plasma to leak out of these small vessels, filling up the spaces around the cells, putting pressure on pain receptors and causing pain. You know, so pain receptors do not adapt to pain. A lot of general senses we get used to, and special senses. You get used to an odor, you get used to a background sound. People that live near the interstate, for example, get used to the sounds of traffic. They don't hear the noise. Or they live near a railroad track. They don't pay attention to the train going by anymore. If you have an older house, maybe you have an older house, maybe your grandparents have an older house and have gas heat. And older houses with gas heat all have a certain odor to them from the gas, the accumulation of the natural gas. It's just been, it's not lethal or anything like that, but it just has a certain odor to it because of the gas that they don't notice, because they're living there with it every day. Those kind of receptors respond to, they adapt to stimulus. We adapt to the feeling, to our clothes on our bodies. We don't pay attention to the pressure of our clothing on our skin. We adapt to it, but we don't adapt to pain. We don't adapt to any kind of pain stimulus, because pain is our body's way of warning us that something is hurting, something is going on that's bad, so we don't adapt to pain. Pain is protective in that sense. The nociceptors are free nerve endings. We can have fast pain, we can have slow pain. Fast pain is acute pain. You step on something sharp. You discover a Lego while you're barefoot in the middle of the night. You bump your the anterior crest of your tibia, your shin bone. You stick your finger accidentally. You get a paper cut. All that is acute. Sharp is fast pain. Slow pain is a headache. Slow pain is a sore muscle. Slow pain is reflux. All of this, or an ache in your bone. All of this is slow chronic pain. Two different types, acute or chronic. Pain tolerance and sensitivity to pain, get tossed about a lot. Everybody perceives pain at the same intensity. The pain receptors in everybody works the same. There's no variability on that. Pain receptors in everybody works the same. But the tolerance, the ability to respond to this pain is going to be varied. If you have a patient that says they're very sensitive to pain, it means that they have a low tolerance to pain, but not a low pain threshold. So the intensity is always the same. We all perceive pain at the same intensity. So we don't, perceive it. Some don't perceive it more than others. No, the perception is going to be exactly the same. The pain threshold that triggers pain is exactly the same in everybody. Pain receptors will be triggered at exactly the same threshold all the time in every individual. Threshold level, like threshold for the action potential in a muscle cell, it's going to be the same threshold for everyone. That's how pain receptors work. They have to hit threshold or they don't work. Pain sensitivity means that they don't deal with pain well. That's the low tolerance. So while everybody gets the same stimulus intensity, everybody gets the same threshold of pain, it's how our bodies respond to pain. That is the pain tolerance. How well can you deal with it? There are people that prefer to have no local anesthetic when they have dental work done. Do it and get it over with. There are others that need to be anesthetized before they get out of the car, before they go into the dentist's office, because of bad experiences. Previous experiences with dentists were bad. So it has to do with the tolerance to pain. How well can you handle the pain? Many people that have pain tolerance don't take, can work through pain or play through pain. If you're an athlete, pain tolerance. How well can you tolerate the pain? But everybody perceives the pain at the same intensity. Everybody perceives the pain at the same threshold. Okay, now, something else that pain does to throw us a curve is what's known as, we have visceral pain and referred pain. Visceral pain occurs in the viscera, the internal organs, either in the abdominal cavity or in the thoracic cavity. You have acid reflux. You have pain in from your gallbladder, for example. You have what you say are stomach cramps. Well, they're not really stomach cramps. They're swelling. You have swollen, the small intestine swells because of gas buildup. That's visceral pain. Maybe your patient may be having a heart attack. That's visceral pain. They may have appendicitis, an inflamed gallbladder, a kidney stone. That's all visceral pain. Anything internal in the viscera. Referred pain is different. Referred pain is where you perceive pain coming from one part of your body when it's really generated in another part. For example, referred pain, pain from one body region perceived as coming from a different region. Your patient's having a heart attack. Your heart sets in the center of your chest, more or less, slightly off center underneath the sternum. But your patient has pain down their left arm, or they have pain in their lower jaw on the left-hand side. How come? Well, the same nerve that innervates the heart, the vagus nerve, also innervates part of the arm and part of the jaw. It also innervates all the way down to the abdominal cavity. Sometimes pain in the abdomen is an indicator of heart attack pain. Sometimes back pain is an indicator of heart attack pain. But the pain signals do this because visceral pain and somatic pain travel the same pathways. So our bodies are often fooled into thinking, since it's traveling the same pathway as another type of pain, that's where it's coming from. It's gallbladder pain. The gallbladder is located on the right-hand side, the upper right quadrant, directly underneath the liver. It's a little organ about the size and shape of a kiwi fruit, but the color of a kiwi fruit also, because the gallbladder is green. Now, pain in the gallbladder often occurs underneath the rib cage. Well, that's fine, that's where it's supposed to occur, but it can also occur over the right shoulder. Frequently occurs over the right shoulder because the same nerves that are leading to the brain from the pain receptors in the shoulder are passing through the same pathways as from the gallbladder. So gallbladder pain sometimes shows up in the shoulder, which is really, really bizarre to think that my gallbladder is acting up because my shoulder hurts. Lower back pain can be caused by pneumonia. The lungs are, the pain from pneumonia can show up in the chest or in the lower back. As also heart attack pain can do that too. If you ever hit your elbow and stimulate your funny bone or your crazy bone, however you call it, what you're doing is you're stimulating the ulnar nerve. Now, the ulnar nerve runs along the ulna. You have a radial nerve that runs along your radius and an ulnar nerve that runs along your ulna. Now, if you hit your elbow, you have a tingling sensation, but not in your elbow. You feel it in your fingers. Your fingers you feel like there's something happening to your fingers because the pain sensation is traveling the same pathway that pain from your fingers would travel. So your brain says, oh, my fingers are tingling. And we get fooled all the time. So referred pain, while pain is a good thing for us to tell us something's going on, it's not always a good indicator of where the problem is. Now, sometimes it's obvious. A person's leg is broken in 3 places and their bone's sticking through, and they say, my leg hurts. Well, that's probably not referred pain. But the patient that presents with a very sore right shoulder with nausea and vomiting and lots of gas may be having a gallbladder attack. Kidney stones can have pain anywhere across the whole side of the body in the abdomen. Kidney stones don't play by the rules either. So the Pain often fools us where it's coming from. You can't just assume by the pain that that's where the problem is. Appendicitis normally is expected to have pain in the lower right quadrant, right above the appendix. But in some cases, the pain in the appendix can start in the middle of the abdomen. So I had a friend in college who had his appendicitis pain start on his left side and didn't migrate over to the right side for 2 days. Nobody believed he had appendicitis until the pain started showing up on the right-hand side. So so pain doesn't always tell us where it's supposed to be. This is a map of the referred pain areas that we see. For example, gallbladder there and the right shoulder. Heart attack pain down the left arm, anywhere in the chest, even in the lower jaw on the left-hand side. Just because your patient presents with a really bad toothache in their mandible on the left-hand side doesn't mean it is a toothache. You can't get tunnel vision when you're looking at your patients and you're assessing them and you're using pain. Oh, absolutely, it's only a toothache. You got to be careful. You always have to start out broad and narrow things down. We see the appendix pain can stretch anywhere across this quadrant in here. This is kidney pain, can be anywhere on the flank, on the side, down the inside of the legs. All of this can be affected by the pain from the kidneys. There's the lungs and the diaphragm can cause pain to occur up here at the top of the thoracic cavity. So there's lots of things, lots of events that pain can throw you a curve on. So you have to be very careful when you're assessing that, to understand that just because one area hurts doesn't mean that's where it's coming from. Something else that happens to our sensory receptors is that they adapt. I mentioned this already. Touch receptors adapt. We're not aware of our clothing unless there's a tag that's bothering us, and we're aware of that all the time, but our touch receptors adapt. Pressure receptors adapt. Sound, we adapt to noises. We adapt to odors. We don't adapt to pain. We don't adapt to positions in our bodies. We don't get used to one position and one position only. And we most certainly do not adapt to the chemical makeup of our blood. We are always monitoring and adjusting our blood makeup, because we're always breathing faster, breathing slower, altering the retaining water, getting rid of water, retaining sodium, releasing sodium. We're doing all that to adjust the makeup of our blood all the time. Pain doesn't adapt at all. Keep that in mind. Now, proprioception is our awareness of position. Proprioceptors are embedded in the muscles, the tendons, and the joints. They tell us how fast our arms and legs are moving, with what velocity, what kind of force we're using, and what are the limits of our arms and legs. We interpret the stimulus coming from the proprioceptors as well as our equilibrium and touch and pressure and pain and stuff like that to tell us where we are, what we're doing, and are we moving? Are we accelerating? Are we slowing down? Proprioception allows you to be in a car and if you're, sitting in the passenger seat and the car's going there sort of half asleep and you're dozing, you can tell when the car accelerates, you can tell when the car turns a corner, you can tell when it brakes by changes in your inner ear and changes on the proprioceptors detecting the movement of your various limbs without having your eyes open. You're dozing. You're aware of this, but you're not really having to watch everything. Don't do it while you're driving. So proprioception is a constant event. So we don't adapt our proprioceptors. We are allowing we stabilize ourselves as we move. We go up a flight of stairs, we go down a flight of stairs, we run, we walk, we ride a bicycle, we drive our car. We monitor our position all the time, and we're always adjusting our muscles so that our body stays in balance. If we overload our proprioceptors and our equilibrium with stimulus, we're often dizzy. You go to Dollywood and you go on one of the rides, that will spin you around. Not like talking like the Eagle or something like that, where you are flung in different directions repeatedly, like the tilt-a-whirl or something. And you get off and you're dizzy because your inner ear is still spinning around. Your body isn't, but your inner ear is still jarred. Your proprioceptors have been assaulted from movement from different directions. And so you are trying to walk straight and you can't. You're dizzy. Some people get so dizzy they become nauseous and start vomiting. We adjust our movement. Let's say you go for a hike. You go up into the national park, and you're hiking up to Mount LeConte, for example, or Mount Camerer, or one of the other ones that have numerous trails, and you have to adapt to the changes in the trail all the time. You don't pay attention to what you're doing, you fall. Proprioceptors are allowing us to walk without stumbling, without tripping. We allow us to respond. Proprioceptors also allow us to respond very quickly. So if you trip, you recover, or you fall down. But a lot of us will trip, and bump into something, and then we recover very quickly. We don't have to stop and think, oh, I tripped over that log. I better put my arm out to the side and grab onto something and shift no, we don't do that. It's automatic. We also use proprioceptors to control our antagonistic muscle pairs, like the quads and the hamstrings. So that's when one set of muscles is contracting, like the hamstrings are contracting, the quads are relaxed. The proprioceptors prevent both sets of muscles from contracting at the same time, because that wouldn't, first of all, it wouldn't be effective. Secondly, it would hurt, and it would negate the action. It would simply overwhelm the action. You wouldn't be able to do anything. So the proprioceptors inhibit one side or the other, depending on what you're doing. So I consider this is a good example of how a proprioceptor works. You have an empty bag, and someone is giving you, let's say that someone is going to give you you're at the grocery store and you're going to put a bunch of potatoes into a bag because you're going to pick out the best of the bakers or whatever, or the Yukon Golds that you want. Someone's throwing them into a bag for you. So you're holding your bag at waist level, and as 10 pounds of potatoes suddenly enter the bag, you're going to lower that bag is going to, the weight of that bag is going to force your arms down. The muscle cells will stretch as the weight drives the arm down. But then the structures inside the arms are called muscle spindles. That's a type of proprioceptor. The muscle spindle is stimulated when the weight drives your arms down. But the muscle spindle sends a signal to your arm muscles, and you bring the bag back up. You maintain tension in the muscle. So if you stretch the muscle spindle, it will become activated to contract the muscle and bring it back up to where you want the bag. So now there are three types of proprioceptors. There are muscle spindles found in skeletal muscle cells. There are Golgi tendon organs, nothing to do with Golgi apparatus. Golgi tendon organs right at the point where a muscle and a tendon come together. And you have joint receptors found in the capsules of the joints, like in the synovial capsules. That's where your joint receptors are located. These are all mechanoreceptors, very sensitive to stretch and what's what I'm looking for? Stretch and contraction. Stretch and contraction. So there we go. These are the muscle spindles embedded in the muscle cells themselves. They measure the velocity that the arm or the leg moves. They measure the movement, what it's doing, up, down, left, right, sideways, how fast we're moving the arm, what direction are we moving it. It measures that by measuring the change in the length of the muscle and how rapidly that change is occurring. The Golgi tendon organs determine the load on an arm or a leg. Here we see the muscle cell. Here we see the capsule. Here we see the muscle cell. Here we see the tendon right here. The Golgi tendon organs are located right in here at the junction between the muscle cells and the tendons. And they will tell us what kind of load we are applying to that muscle and how the muscle can respond. If the load increases, the muscle will contract and become more forceful. If the load decreases, then the muscle will contract less. But the Golgi tendon organ tells us what is the load we're dealing with. For example, picking up something heavy as opposed to picking up something light. What force do we apply to do that? And here we have within the joint itself, we have the joint kinesthetic receptors. The proprioceptors determine the exact location of any specific joint. And they tell us when we are overextending a joint. When we are at the threshold action, these joint receptors tell us that's too far or that's far enough. We can't go any further. So at the extremes of our action, we have these joint kinesthetic receptors saying stop. Now, in our bodies, we have what is known as conscious and non-conscious or unconscious proprioception. Conscious proprioception tells our brain, hey, here's what we're doing. We're aware of it. The cerebrum, the cerebral hemispheres, the two large structures of our brain, we become consciously aware of our action. Non-conscious proprioception goes to our cerebellum, where we store our muscle memory. We store a lot of our learned reflexes. We don't stop to think about that action. Whereas the cerebral hemisphere, we can think about, we're aware of the perception, the proprioception, and we respond. But non-conscious, we respond automatically. A reflex. The human proprioceptive reflex, or the writing reflex, is an example of a non-conscious proprioception. If you lean over in any way, if you tilt in any direction, we will turn our head back. If we lean over, we will straighten our head so that our eyes are level with the horizon. That is a non-conscious proprioception. We do that automatically. Whatever position we're in, we will frequently will usually tilt our head so that we're looking at things straight. The cerebellum does this. The cerebellum helps to control our balance, or works with the inner ear to control our balance. The cerebellum is sort of like our balance center, if you will. And so if we are leaning or tilting, if we are riding a bicycle or bent over, riding a bicycle, we'll still raise our head up to keep our eyes level with the horizon. And we'll frequently see that when someone's riding a bicycle, they're not looking down, they're looking straight ahead. That's a reflex. That is this is the righting, as in standing up, sitting upright reflex. The human proprioceptive reflex. We do this all the time. When we say someone has good eye-hand coordination or hand-eye coordination, it is a proprioceptive response. Eye movement is coordinated with hand movement to use the visual input to guide our hands to catch something or, move something, to grab at something. Hand-eye movement, very good hand-eye movement, the hand-eye coordination. You see something, someone throws something at you, you catch it. You don't stop to think about it. And sometimes, we say it's a reflex. Well, it sort of is, but it is, a response. The eyes work with the proprioceptors in the arm and the hand to put the hand in the right position to catch the object as it's coming at you. That's what eye-hand coordination is all about. Let's see. Reflexes. Reflexes are nothing more than an involuntary response to a stimulus. When you put your hand down on something hot, you yank your hand back. You put your foot down on something sharp, you yank your foot back. This is a spinal response that does not involve the brain. It literally is a no-brainer. Pardon my little pun there. But a spinal response has no brain input. Because we don't have the time to send a signal to the brain and have the brain process it and send it back down. We want to get rid of the pain right away. So we yank our foot up or yank our hand back. We don't, and while we're dealing in milliseconds, why tell the brain? The brain becomes aware of it. To us, it's an instantaneous, hey, that hurt, Right, well, it hurt, but you yanked your foot back. So the brain's aware of what happened. It just takes a little less time if we yank our foot back first and then tell the brain. So, reflexes are either inborn, they are intrinsic reflexes. They are always predictable. This is an important thing to remember. Reflexes always produce, inborn reflexes produce a involuntary, predictable response to a stimulus. You will turn your head to the direction of a sound or a bright light every time. You will yank your hand or your foot back from something sharp or hot every time. Posture. Maintaining our posture is an inborn reflex. Learned reflexes are just what they sound like. These are reflexive actions that get better with lots of practice. Learning to drive or riding a bicycle are reflexes that occur, reflexive actions. You don't have to stop. Oh, there's a stop sign. I had better get my foot on the brake pedal now so I can stop. Oh, okay, I've driven through it. Too bad for me. So now, reflexes are always fast. Good example here. of hand-eye coordination, it's not working, or reflexive action, it's not working. So, but this is a learned reflex. The third baseman doesn't stop to think what he has to do. He blocks the ball, picks it up, and throws it to first base without stopping to think. He doesn't have to think. He knows what to do. That is a learned reflex that has gotten better and better and better with lots and lots of practice, as opposed to this intrinsic reflex here, grabbing the ball when it comes at you. So it isn't working. The reflex arc, what we call the steps in the reflexive action. Oh, hang on a second. Sorry, my dogs were getting real excited about some sort of strange air molecule floating around outside. Okay, reflexive arcs, 5 parts to it. The receptor, something gets stimulated. The pain receptor, for example. A sensory neuron sends the signal to the integration center, which is usually the spinal cord and or the brain. It determines what the response should be. The integration center determines a response, sends a signal out on a motor nerve to an effector, which is usually a muscle, to lift your foot off the sharp object or pull your hand away from the hot object. And so you respond. That's a reflex. This is what the reflex arc looks like. There's the stimulus, a pin in the skin activating a pain receptor. The signal travels from the pain receptor through the afferent neuron to the integration center out here. That's the sensory neuron. It determines what action we should take. It sends a signal out on the motor neuron to the effector, and we move our hand, we move our foot. Reflexes are also either somatic or visceral. If it's a somatic reflex, it activates skeletal muscle. If it's a visceral reflex, it activates smooth muscle or cardiac muscle. Our digestive system will squeeze food through the digestive tract if there's food present. That's a reflexive action. We will always push food through our digestive system when it's there. That is a visceral reflex. We don't stop and think about it. This is a good example here of a typical reflex. We've heard of this plenty of times. The knee jerk reflex. If you tap the patellar tendon, you'll stimulate the leg extending. The leg will extend. Because what you're doing is what will happen is the proprioceptors in that tendon will activate the quadriceps muscles. Remember, the quadriceps cause the lower leg to extend. And so by hitting that tendon, you stimulate the Golgi tendon apparatus, causing that muscle to contract. And this is how it works. There's the mallet. We hit the patellar tendon right there. That causes the tendon stretches. That makes the Golgi apparatus think that the the muscle is stretching, and that makes the spindle fibers, the muscle spindle think that the muscle is stretching, and it will cause the muscle to contract, and so the leg kicks out. And it will also inhibit the hamstrings from responding. So you have this type of response here. And what you're doing is if you hit the patellar tendon with a mallet like that and you get a kick out, it tells you that we are adequately processing information here in the central nervous system. And we depend on the muscle spindle in the quadricep muscles. We just depend on the patellar tendon and the Golgi apparatus, the Golgi tendon in here, telling us that, hey, we've been pressured, we've been stimulated, we're contracting. We make the muscle spindle and the Golgi think that we're contracting by hitting it with the tendon, and it causes the leg to kick out. We cause the extension of the lower leg. And that is everything on the general senses and reflexes. So let's get out of here. Okay. So any questions on anything? Okay. Then I'm going to get us out of here, and I will see you all in lecture on Thursday.